to November Health in Hackney. I've had apologies for absence from Councillor Kennedy and Dr. Sandra Husbands. This is a hybrid meeting, some people in the chamber, some remote. We're being live streamed, we're being recorded, the press may be watching. Please mute yourself unless when you're speaking. Please keep your camera on if you're a participant in the meeting unless you've finished your slot. Please don't start conversations in the chat. I haven't been notified of any declarations of interest other than the standard items of which we're all familiar. And so with that, I will go straight to the first substantive item, which is item 4. And Helen Woodland, our Director of Adult Social Care, has provided a very helpful presentation in the pack as to what is adult social care. Helen, over to you.
Thank you, Chair. Can everyone hear me?
Yes.
Good. All right, that's good. So I'm not proposing to talk through the whole slide deck because I am assuming that you want a substantial amount of time for questions. So all I would do, I suppose, is draw people's attention to the national picture. So just to be clear, adult social care is here to support people and their families and their carers to achieve the outcomes that matter to them. So that might be about maintaining their independence, it might be about being safe, it might be about providing statutory care and support, or it might be about signposting them to other organisations, including the voluntary sector, that can help them. Unlike our health services, adult social care is not free at the point of contact. So we do financially assess people who are deemed eligible for services, and most people, even those on lower incomes, will be required to pay some contribution towards their care. Now that might be £3 a week, or it might be all of their funding. So nationally, I think people will have seen in the press that we are struggling. So we have an ageing population. We also have a number of younger adults who access adult social care, who are with us for their life course, really. And in order for us to support the growing demand, that costs us more. So estimates will tell you that over the past decade, the cost pressure nationally has increased by 8.5 billion, and the total funding for adult social care has increased to 2.4 billion. So that's quite a big gap. And of course, that's only been made worse by COVID. One of the things that has been quite topical recently is our workforce. So we know that adult social care has a vast workforce, but we also know they're an ageing workforce. And we know that there's quite a high level of vacancies. And that's likely, we think, to be exacerbated by the requirement to have mandatory vaccines, which has already come into place for our care homes and is likely to come into place for other care settings, or will come into place, sorry, for other care settings in spring of next year. So in Hackney, the picture looks something like we've got about 280,000 residents who are over 20 in Hackney. But only 1.7 of that population are actually supported by adult social care. So we spend quite a lot of money, over 30% of the overall council budget, on quite a small number of our residents. Again, of those people who access adult social care, about 40% of them would have been working age adults or under the age of 65, and about 1,900 of them would be over 65. So we support our residents in a number of ways. It may be that they require residential services like a care home, and that might be a nursing home or a residential home. Wherever possible, we try and support our residents to stay in the communities that they're from. So we try to support people to stay at home. So actually a large number of people in Hackney, probably about 1,600, actually receive home care. So that's support in their own home. So we've included information on where we spend our money, and you'll note that about £27 million of our budget actually goes on residential and nursing care. And that's significant in Hackney because actually that means that we send quite a lot of our residents out of Hackney because we don't have a huge amount of provision for residential and nursing care in the borough. We've got, I think, 15 care homes, 4 of them specifically for older adults. So about 457 of our residents who actually have residential or nursing care are supported outside of the borough. As I've mentioned, the workforce is quite a big challenge for us. So whilst we have a shortage of people who are working in our commissioned care services, so people who work in care homes or deliver home care, there's also a shortage nationally of social workers. So we are competing with all other boroughs and councils up and down the country to recruit the suitably qualified and skilled social workers that we need. As I said, I think we are waiting to see what the impact of mandatory vaccination will be on our overall workforce. So we've touched a bit already on challenges, but much like everywhere else in the country, demand for care in Hackney is increasing at a time when our overall funding is reducing. And that has been made worse by the impact of COVID. We're seeing many more people going into our hospitals, which means that we are supporting many more people to be discharged from our hospitals. And that's a significant pressure on us as a system. I'd be remiss if I didn't mention the added pressure in Hackney around the cyber attack. So in an already quite fragile system, the cyber attack has added another layer of complexity to that. And I think the other thing to note is obviously we are working closely, and we're delighted to be working closely with our wider system partners around developing an ICS. That's an integrated care system for those people who don't know, which is hopefully a different way of working and a closer, more integrated way of working across the whole health and care system going forward. So I think I'll probably stop there because I imagine people have questions on specific things.
Thanks, Helen. Can I just start off just to pick up on one of the points? In terms of both what you've said in terms of the COVID pressure, more people going into hospital and thus needing support being discharged, but also generally a movement towards shorter stay in hospital discharge. I mean, is work underway, or with the ICS, is there space to do work to look at how budgets flow and follow that pattern, to make that a more sustainable, because obviously it's not if the funding doesn't really follow that pattern, which is upon us.
Yeah, absolutely. So one of the principles of developing an ICS is a shift, including a shift in funding to more preventative services. And some of that is being achieved in Hackney through things like our neighbourhood programme. But absolutely, we are having discussions as a system about where the pressures are and where the limited amount of funding we have is best used going forward.
How would you expect that to sort of manifest itself in a practical way that you could tell us about or you understand? I mean, is that obviously the ICS is still at design stage, but how are you going to make that more of a reality as far as you're concerned?
So I mean, there are significant shifts already. We have been talking to our health partners very recently about additional funding for winter pressures, which we have agreed. So we will have additional funding coming into the system. We're lucky in Hackney in that we have a number of integrated functions around discharge already. Sorry, excuse me. So we have an integrated discharge hub. We have an integrated treatment team that supports people when they come out of hospital. And for me, those are a priority to look at further development and to further enhance, because these pressures are not short term as such. They are likely to be ongoing. So we need to be clear that we are doing the best thing and the right thing for our residents and supporting them to leave hospital as soon as they can and to regain as much independence as they can. I think you're on mute, Councillor Hayhurst, sorry.
Sorry, thank you. Councillor Kennedy.
Thank you. I did quickly want to come in on, because absolutely you're quite right, Chair, you are probing how funding of this in the new ICS will work, how it will be taken forward. The constitutions for the individual ICSs in draft forms will start coming out before Christmas. How much those constitutions talk about the financial relationships and how they are laid out is still to play for, I think. I've come fairly fresh from a briefing at which Chris Naylor from the King's Fund, who've done a lot of investigation and work into how ICSs, particularly the London ICSs, might work, is recommending that we try and get into our constitutions as much clarity as we can about the devolving of funds and funding arrangements. A certain amount of scepticism at that meeting by some of my fellow cabinet leads across London was expressed as to how easy or difficult that is going to be. But still to play for, I think, is the message.
Thank you, Councillor Kennedy. I saw Cllr Adams first, then I'll come to Councillor Snell. Cllr Adams.
Thank you, Chair. So my question is very simple. In your paper, you said any adult is entitled to an assessment. I'm just wondering if you could elaborate a bit about how to go about getting this assessment, because there are so many people, for example, in my ward, that most of them don't know how to get this kind of assessment.
Absolutely. So the quickest way is to contact our contact centre. You can ask for an assessment via your GP, or sometimes we get referrals from health professionals from other parts of the system. But if you have a resident or a neighbour or a family member who would like an assessment, if you contact us, then the contact centre will ensure that you are assessed. I have to be clear, there is a waiting list at the moment. So we do prioritise and assess everyone who approaches us to make sure that we're managing risk. So we do the most urgent assessments first, but we are running a waiting list of about 6 weeks at the moment, which we're working very hard to reduce.
And just before I bring in Councillor Snell and then Laura Sharpe, Helen, how is the service centre kitted out to deal with different community groups, or equipped to deal with different community groups in Hackney in terms of does it have on rotation a Turkish Kurdish speaker to be able to field those that can't speak English as their first language? I mean, and what scope is there? What scope is there to improve upon that?
Yeah, so we're working very closely with our contact centre colleagues to improve access. I should be really clear that a lot of our clients who approach us, it's a telephone assessment won't work for various reasons. So when someone, either because of communication challenges, and that might actually be a sensory impairment issue, or because they might have dementia and they're a bit confused, or simply because it's better for us to do a face-to-face assessment, we will schedule a face-to-face assessment. And we have been doing that throughout the pandemic, because we recognise that our clients are often very vulnerable, and often we will have to see them. I think it's probably also worth making the point that I think it's about 7,000 people who contact us a year asking for an assessment. Actually, only 4,000 of those go on to have an assessment, and only 3,500 of them go on to need a service. So it may not be that actually you need adult social care. It may be that you have other issues that we can help signpost you to the most appropriate service for. But in any case, my advice would be, please contact us and we'll make sure you get to the right team and the right person.
But just have you got a plan, or do you want to do more work to try and improve accessibility, whether it be through language barrier or through cultural barriers? And have you got plans afoot to try and improve upon that?
We do. So we have a whole adult social care transformation programme. and the first segment of that is looking at our offer and our access offer at the front door. So one of the things we're talking about is developing multidisciplinary wellbeing teams, so that actually, if you contact the council, you're contacting us for a reason, and we would far rather solve that than say, sorry, you're not eligible, please go away and come back when you are. And the best way to do that, similar to the neighbourhoods approach, is to have a multidisciplinary team that can deal with the various issues that residents have when they contact us.
Councillor Snell.
Two questions. The first, I imagine, is simple clarification, so we'll ask both together. Your paper talks about basically more people needing ongoing adult social care on discharge from hospital. And my assumption was we were talking about long COVID, but have I understood that correctly, or are there other reasons why more people are being discharged and need ongoing social care? The bigger question was my concern about addressing both staffing needs and also ensuring we don't lose too many staff through non-vaccination. I have been worried throughout the pandemic that it does appear that a large part of the social care staff are very atomised and therefore perhaps not benefiting from the programmes we know have run in the Confederation and the CCG before, where we were picking up frontline staff, offering them a development a pathway, so they could actually then progress into higher paid, better jobs. And I'm wondering, in the wider changes that you're proposing, whether we should not be assessing people through regular appraisals, start by making sure that they do get their jabs in time, but then also talk about this wider career development. So it's not just a stick, it's actually helping people to keep their jobs and progress in their jobs. I mean, are we geared up to do that? Because I still feel there's too many separate providers and we haven't got a handle on their current status and their needs.
Okay, so there's quite a few separate things there, Councillor Snell, so I'll try and take them in turn. The increase in demand is actually very little to do with long COVID at this point. And that's not to say that it won't become a pressure for us, but actually what we're seeing is probably a lot of people who managed quite well prior to the pandemic, but for various reasons, social isolation, anxiety, a number of things, are managing less well post-pandemic, and are finding that they then need support. And in most cases where people are assessed as eligible for support from adult social care, that support will be ongoing. So long COVID isn't really a significant issue for us at this point. That's not to say it won't be going forward. In relation to vaccine, we have an entire strand of work, a programme that is looking at vaccine for adult social care and the workforce. And there is a team that works on that and works very closely with our GP Confed to do that. And that covers both our residents who are in social care provision and also the staff that work in that provision. So our rates of vaccination, certainly in our care homes, are actually pretty good. So 94% of all of our staff in care homes are now vaccinated. We have 2 that are exempt. And we have contingency plans in place with every care home provider to work out how they are backfilling any vacancies that have been created by people not wanting to take up the vaccine offer. Our rates across the social care workforce in general, including our own staff, are 75%. And we know we want to get them much higher than that, and we have until spring to do that. But we have specific plans that relate to specific providers and specific workforce areas, and are working very closely with those providers and staff to overcome whatever hesitancy and barriers that they have in place. So we're relatively confident. We will obviously be happy to keep you updated as we go, that we will be able to achieve quite high levels of vaccination across the social care workforce by the spring deadline. In terms of workforce development, I think it's a very valid point, and I think one of the challenges we have is that there is not as much national emphasis on a national development pathway for people in social care as perhaps we would want there to be, and that means that we probably need to put more emphasis on it locally. So as part of the transformation, one of the strands of work is specifically around progression and career development, and that includes our own staff as well as our commissioned staff. We are developing what we're calling a skills academy that has very specific pathways so that people, for example, who are non-qualified social work care assessors can follow that pathway and achieve that qualification if they want to. And similarly, we have pathways for staff who deliver our care via our providers. And what we're doing is co-producing those with the staff to say what type of support, what type of training and what type of qualifications do you want to see. And we will be developing that and launching it over the next 6 months to 9 months.
Thanks, Helen. Just building on that, I mean, obviously part of staff retention is obviously to do with being valued and staff appraisals. How are we on regular yearly staff feedback sessions and appraisals? Where do we fit there? Is there room for improvement, or are we doing okay?
I think there's always room for improvement, Councillor HUHFT, but to be clear, part of the professional supervision for social work and social care staff is that they have to have regular supervisions. So we have a supervision template and we undertake supervision audits to check that the quality of those supervisions are happening. I think it's probably fair to say that that's been disrupted slightly throughout the course of the pandemic and cyber, so it's something that we want to refocus on. But we have to do very regular supervisions for all of our social workers, and they all have annual appraisals that link back to objectives that are set at the beginning of the year.
Thank you. Laura Sharpe.
Thank you, Chair. Helen, I wonder if you and I should have a conversation, because it sounds quite amazing what you're doing around the workforce development. And I'm the SRO for the, oh God, anybody who's listening to this won't know what we're talking about. The Senior Responsible Officer for the ICS for Workforce. And we're just sort of starting to think through what that actually means. And there could be some opportunities here that where we could do some common work potentially, or common training and development. There is a small pot of non-recurrent money for sort of investing in workforce infrastructure to help. So maybe outside of this meeting, you and I should have a chat.
Absolutely, Laura, that sounds great.
Thank you.
And just, I mean, I don't know to the extent, I mean, it's often something I've sort of thought through. It's maybe harder to do as far as housing is concerned, but the extent to which we can create a Hackney package, now whether that be sort of free leisure facilities or, you know, bundle up as much as you can, what can Hackney offer on a workforce level to employees to make it as attractive as possible, thinking laterally across the system. I mean, I've often thought about that in terms of sort of key worker housing, retaining, you know, key middle management as they might be wanting to move out, etc., etc. But I just still think there's more work to be done there. Destination Hackney as a place to work, wrapping in everything we've got to offer, could be quite a sort of neat package that I'm not quite sure we've hit yet, in a very difficult climate. But I don't know what people's thoughts are on that.
Yeah, so just to add, I fully agree, Councillor Hayes, that's why it's one of the priorities in the transformation programme. We also have created a new assistant director post, which will be the assistant director of, a bit like Laura, I've lost my train of thought. It's safeguarding, quality assurance and workforce development. So specifically to focus on workforce development, and they are starting on the 10th of January.
Any other members with questions? I had another one for Helen. Helen, I mean, Councillor Adams?
Briefly, you know, in your presentation, you said that 68% of the patients, they are like, outside the borough. Do you think in the long run it would be cheaper for us to have home care in Hackney to accommodate these people?
Yeah, so to be completely clear, that's only the percentage of people who receive residential services, so residential or nursing care. But you're absolutely right, Councillor Adams, and one of the strategic priorities we've been discussing is the development of more services within the borough. And I think that goes not just to it being cheaper, but also to what kind of borough we want to be. Because we don't want to send our most vulnerable people away from the communities they know and love and everything that they understand. We want to be able to support them closer to home, closer to their families and closer to everything that they know. So absolutely, that's a priority for us to develop.
I mean, the challenge there, as I understand it previously, has been obviously in terms of location with, debates over Medium Road, whether it is used for sort of facilities like that or more for temporary housing. And I mean, how far along are you on a sort of spend to save analysis with Ian Williams as to working out feasible options for pushing that forward?
So I think what we're doing is thinking slightly more laterally, because what I also don't want to create is ghettos. So we want to build homes that are part of communities. So that to me, there's no.
Just sound there, Helen.
I think she's
You're showing us mute, Helen, for some reason.
Sorry, I don't know how that happened. So I'm not sure what you heard and what you didn't. But what I was saying was, to me, there is no conflict about using a site for mixed housing. In fact, that's a positive thing. We want to create multi-generational communities. We don't want to create silos or ghettos where older people or people with vulnerabilities live, because that doesn't help them stay connected to their communities. So I'm working very closely with Ian and with Stephen Haynes, and we have been discussing it with Cabinet and with the Mayor. And I think the other thing to bear in mind is that the ICS gives us an awful lot of potential to think more broadly about all of the real estate that we have in Hackney and how we best use it to meet the needs of all of our residents.
And sort of as maybe the wrap-up question, but I forget how long you've sort of been in post now, Helen. I mean, obviously you've come in. You've had to deal with COVID. You've got a changing situation in terms of ICS. But in terms of what you want to, on a personal level, achieve in this very difficult climate, I mean, in a year's time, what will you be judging yourself against? What's your what sort of tangible, goals have you got for yourself in terms of improving the system in Hackney?
So I've been here since March, and I think that some of my goals are tempered slightly by the situation we're in around cyber and COVID and what's realistic. But I think the real acid test is what our residents tell us. So for me, it's something around better engagement, which is also part of our transformation programme, and being very clear what isn't working for residents at the moment and being able to ask them in a year's time, has that improved for you?
And are there, and how do you measure that in terms of what sort of satisfaction surveys or?
Yeah, so we're looking at building into our revised process and assessment forms, very clear sections that ask residents what they wanted to achieve and then review whether they've achieved it. So we should be able, with the new processes we're putting in place, to be able to say very clearly, this is what residents told us they wanted and this is what they tell us, have we been successful in supporting them to achieve that?
Thank you. Any other members for questions before I bring this item to a close? Well, I think with that then, I'll bring this item to a close. Helen, thanks a lot. That presentation I think was incredibly useful. I think it's one that will certainly a useful training aid memoir as well for future members of the Commission. And thank you very much for that. So I'll bring that item to a close if I can. The next item is in terms of the Homerton and net zero, and grateful to be joined by Tracey Fletcher, who's the Chief Executive, and Liam Triggs. Tracey, before we go into that presentation, I think I flagged with you through Jarlath, just in terms of just the immediate structure that's happening on a Hackney level. I just wanted to ask you about. So as I understand it, Siobhan's post, who's essentially been the quasi David Mayer, fulfilling that sort of more management role, is not going to be renewed. And what I understand, I could be wrong, is that as well as being the chief executive of Homerton, and as well as sort of doing Mark's old job, we were also going to be doing David's old job as well. And it's just if I've sort of got this right, or is the structure very different? So, and we're just sort of asking how have you got capability to do Siobhan's job if that is what is happening, or have we got the wrong end of the stick?
Thank you, Councillor Hayhurst. I'm not sure who Mark is, so I'm not sure I can answer that question. So I think there are two or three things. Firstly, Siobhan left quite quickly. I think rightly for North East London, because TNW has probably got several more sort of unresolved problems than City and Hackney have got, and City and Hackney have got a very robust team. At the moment, in the short term, a number of the roles that, or the tasks or the meetings that Siobhan attended have been divided up between the senior members of that senior management team. I'm providing some direct support to them from a management point of view, and we are about, hopefully, once I've cleared it with Henry Black tomorrow, we'll go out for a director of delivery post that is going to be a joint post between health and care, and that will provide some senior support and guidance within the team, particularly around the service side and a lot of the integration work that we need to consider. As Laura's already articulated, one of the tasks that we have also got to do over the course of the next 6 months is think about how partners take a SRO role in individual functions, and Laura's already taken that for workforce. That is a process that we need to go through over the next several months in order to gear ourselves up to be more of a collaborative system rather than the commissioner-provider arrangement that has been in existence for, well, the past 30 odd years. So there's quite a lot of work to do, and some more support will come in probably in December, I hope, if it all goes to plan, and probably more mid-December now rather than the beginning of December, which is what I was hoping for. But I think things will settle down, and one of the key aims for us is to make sure we're beginning to establish a new system way of working, rather than the previous structures that we've had. And I think final thing to say is I think City and Hackney are ahead of the other two. I don't know what they call them now, BPP areas or ICP areas. The other two areas anyway, BHR and TNW. And to some extent, I think we're in a good position also to provide guidance for those two areas in terms of what we're doing.
Thanks. I mean, I appreciate we're coming from a good place. I suppose it's just a concern that we don't lose some of that through an unclarity of sort of structures and how it all fits together. And I mean, I cannot, this is no reflection on you whatsoever, but you need somebody in a more presumably delivery-based role who can actually drive things through on a day-to-day level across the ICS system. And if you've got, understandably, if you're focusing on the Homerton as well, I mean, it's just, are we at risk of losing some of that ground we're at? I mean, it's just going through this state of flux. It's really just seeking assurance that there's a concrete plan with a concrete governance delivery structure in place for the Hackney and City model that remains, I suppose. And I suppose as soon as we can have some sort of overarching clarity as to what that is, I mean, perhaps I don't know enough about this and I'm being a bit unfair, but I'm just I'm just anxious that we don't lose the ground we've made.
Yeah, no, I don't wish to do that either, and I think the appointments of the joint post between health and care will make a big difference in bringing, I suppose, the work that used to happen in the work streams back to being our centre of our focus, and that will provide a real coordinating role across the patch. And I think the step to make it a joint post is a really positive one that we haven't really had to date. So I think actually once we got that person in post, that'll take a step forward beyond where we've been before, in my view.
Right, thanks Tracey for that sort of impromptu update on that. So can we then move on to the main item here, item 5, in terms of net zero and the Homerton. So thank you both for coming. I'm not sure, do you want to kick off, Tracey, on this before going to Liam?
Well, I'll kick off only in the sense of introducing Liam to ask him to talk to the paper. Liam and his team are people who've done all of the work and continue to put plans in place for us going forward. So Liam actually leaves this week as well from the Homerton, so I will be cheeky and take this opportunity to also highlight that and thank him for all the work he's done. I'll hand over to Liam.
Thank you.
Thank you, Tracey. Thank you, everyone. So there was a presentation which we sent round, which isn't particularly long. It's 10 slides, with the first few slides that broadly set out the NHS's long-term sustainability plans. And then as we go through the presentation, hopefully it will be able to pull it all together and show you what we've done so far and some of the plans we have in place and some of the options we have going forward. But I'm just going to quickly go through the NHS piece to start off with. So where does the journey begin? So I suppose with the greenhouse gas protocol that came out and this link to the NHS plan, we have a number of scopes. So there's 3 scopes. Scope 1 is directly owned emissions, so it's things related to buildings, fossil fuels. Scope 2, which is indirect, which primarily looks at electricity, but it's also things that we purchase that create emissions. Scope 3, which is indirect as well, but primarily looks at supply chain and all of the nuances and issues around supply chain and all the things we purchase as an NHS, which are quite vast and quite ranging, really. The second slide that I actually provided was a breakdown of emissions in the NHS by proportions. Primarily, that's broken into 3 sections, with the largest section being supply chain, which broadly makes up about 62% of all of emissions in the NHS, closely followed by direct trusts. So things that relate to that are energy, buildings, water waste, and then obviously fleet travel, things like patient transport and other vehicles. And the third one directly relates to patient travel, staff travel, and just travel in general. So how do our visitors arrive to us, and what provisions do we have in place for that? Together, they make up broadly about 95%, if my arithmetic is correct, from the plan. And the last piece is just other support services which we actually buy into the NHS. So you can, if you actually have a look at the presentation and the slide, it details all of the individual elements that make up those 3 or 4 categories, and we have started to put plans in place to address each of those individually, and I'll touch on some of those as we go through. On the third slide, it actually goes into a little bit more detail directly related to acute and primary care sites and what are the biggest emission polluters within our scope of works. With an acute site, it's primarily buildings, medicines, and business and supply chain. In the community, again, it's still buildings, but medicines, inhalers are up there as the top 3 pollutants and things that we need to address as part of our scope of works broadly within the NHS. So what has the Homerton done so far? So we've actually been undertaking a scheme of work probably for the last 5 or 6 years with national partners, so part of the National Performance Advisory Group, NHSE and I, and other national and local partners to understand what our What we should be doing prior to the net zero plan, we had a sustainable development management plan, which we worked to, which was broadly along similar lines. So what have we done so far? So one of the things that the Homerton does and has been doing since earlier in the year is all of our electricity is now from renewable energy sources. So all of our electricity is from wind, solar, or hydro assets. That's a great step for the trust and moves us away from fossil fuels and other elements. LED lighting. So we're about 75% completion of upgrading our lighting on the acute site. We still have some work to do in our community sites, but there is a rolling program on all sites of as a failure occurs, we do replace with a preferred fitting, which we have within the trust now, which enables us to keep that percentage moving forward. Plus, we always look to every year to try and tick off another group, another bulk element of our lighting. We have improved monitoring around the trust. So we've partnered with the Modern Energy Partnership, the MEP, and we've been working on them on our energy management. Things like metering and sub-metering, so we can drill down to specific locations and types to see which departments and potentially individual theatres are in most use and use the most energy, and look at individual pieces of kit. So that's an ongoing piece of work. So it's completely data driven and allows us to have the information we need to be able to focus our efforts. We have put things on our glazing like solar film, which for anyone that doesn't know, so the largest heat gains through a building is typically through your glazing. And it's quite a cheap and efficient way of reducing the amount of heat that comes in. So you don't have to then cool the buildings as much, which then reduces your energy consumption and completes the circle of improvements. We put that in mostly last year, and we've seen about a 40% reduction in heat gain in those locations, which is great. We're looking at our hard services, so all of the things like chiller optimization, so cold water chillers that feed our air handling units, that do all the filtering of air and cooling within the entire site, including things like intensive care units and theatres, to optimize those to actually get to drive the efficiency of them. There's up to a 20% efficiency saving that we've actually found from there, and we've actually driven that and been able to optimize those very well over the last period of time. As you may have seen, we've instigated the living wall at the front of site, which looks fantastic, primarily to reduce the particulates from the local vehicles and whatnot going by. Also, it does protect the building, so it stops heat gain, which reduces the amount of cooling we need to have within the actual site and in those buildings affected. We've done a lot of work on waste management. Obviously, with COVID, the quantity of clinical waste has skyrocketed. So we've spent a lot of time with our infection control colleagues and frontline teams to ensure segregation is in place with regards to the waste streams, to ensure things are going in the right bins, for want of a better description, so they end up in the right place. The vast majority of, actually, in fact, all of our waste goes to energy from waste as a bare minimum. We're a zero landfill trust. So that's great, but there's still a lot of work we need to do. And obviously with the COVID environment, it is difficult, but it's something that we continue to push and audit and support our teams throughout. The Homerton is an NHS plastic pledge trust. So this is to reduce the single-use plastics across the site. So working with our procurement and supply chain partners and all of our subcontract teams to just try and reduce the amount of packaging, things like Sharpe bins. One of the initiatives we actually do is cardboard Sharpe bins and recyclable Sharpe bins and reusable Sharpe bins. You can imagine the amount of consumables we use across the site. So we've put some things in place. Also, even things to our coffee shops, the ability to use refills and discounts and incentives for if you bring a reusable cup with you. All of the trust's fleet are the ultra low emission zone compliant. So all of those, they're not all electric yet, but there are plans in place for us to move to full electric fleet, but they are all compliant with the user requirements. We have 6 electric vehicle charging points on site for staff and some of our contractors to try and incentivize people to move to that. And we're also working with our people team to and our leasing partners to get electric vehicles as a priority and to get some better and to improve our deals for staff to be able to gain, if they want to get cars through trust schemes and benefit schemes, then the electric vehicles are beneficial to them and a good price point. We've increased the amount of cycling racks and secure storage on the site. So we have over 500 bike racks across all of the site. We have secure locations. We have a subcontractor and a community team through Dr. Bike who come in and service it for our teams, service bikes. We try and encourage our staff as much as possible to ride to work in a sustainable manner. We're just actually implementing a new wellbeing and sustainability education platform called Jump, which is a number of NHS trusts already, but this looks at how we can engage our staff on the sustainability agenda. It incentivizes staff to complete almost tasks and games and education, and it's almost prize orientated and encourages people to go. It also builds into our sustainability days, which we used to have, but obviously with COVID, they've tailed off, and something we hope to bring in the near future again, where it's a pure engagement day and it's right at the front of the agenda for all of our staff. Obviously I went through what's wider for the NHS. There's pieces on there. So we look at to reuse and recycle as much as we possibly can. So for non-medical equipment, we have a system, a platform called Wall Pits. So you can put your things on it. It's a bit like an eBay, and it goes across multiple trusts, and we can send a table from A to B. So it doesn't involve it going into the rubbish, and it supports reuse and recycling, but also obviously there's a saving there to be had from trusts. And old medical equipment and things that we no longer require or are not quite as energy efficient or not required just in general anymore. We actually go to auction, or we reuse through another platform as well. So they can go to other trusts or other parts of the world to reuse those, so that, again, they don't end up in landfill. One of the things that the Homerton is accredited to the Planet Mark accreditation. So for the last 5 years, we have been accredited to this. So it's a sustainability organization that looks at how we can reduce our carbon footprint and the impact on the environment in general. So for the last 5 years, we have reduced our carbon footprint at the trust every year consistently. Even with COVID and all the additional waste impact and all of the PPE and all of the disposables, we did reduce our carbon footprint by 3%. So not a huge amount, but a great effort with all of the additional things that were going on in the world. So there are all the things that we have done so far. So I apologize for rattling them off quite quickly. But some of the future plans that we have in place. So we recognize that we need to have a formal sustainability governance structure. The trust recognised the importance of this to formally respond to the climate emergency that we are experiencing, and has obviously been brought to a head most recently. We do have a draft net zero plan, which will go through that governance structure to be ratified and agreed, and the appropriate action plans formulated from there. In 2022, we are looking to transfer all of our patient transport fleet across to electric vehicles, supply chain pending, of course. We actually start a trial of our first electric ambulance tomorrow, which is great news. So complete coincidence, I promise, but yeah, that's great news. They will replace our current fleet of petrol and diesel vehicles. We are also working with the public sector decarbonisation scheme. So we've put a bid in for £4.1 million to look at replacing our aging gas and electric boilers and looking at air-cooled heat pumps, which again have been in the press most recently for the most efficient elements to do. There is also other technologies relating to hydrogen, which isn't necessarily cost effective at this stage. But things that they're on the agenda, and as the technology improves, we will definitely keep our eye and see what's the best possible outcomes for that. We're working with the GLA and our ICS partners, and we've put together a bid for the Green Resilience Space Fund, and that's to improve all of the green spaces around the trust. So that includes the park across the road and all the adjoining streets, and East London Foundation Trust also occupy the Homerton site, and just improving the surroundings with that, and obviously to improve biodiversity, etc. We also plan to look at and do a full review of our community sites. So we have approximately 24 main sites and again another 100 satellite sites spread across City and Hackney. There will be a full review of their energy performance certificates and see where we get to, and then look at how we then reform our portfolio as the trust community footprint changes and develops with the ICS and neighbourhood working. And then I suppose the two final ones are also we are in the process with Trust Pharmacy or reviewing our anaesthetic gases to move away from a number of gases that are more polluting than others that are on the market. And we are also doing exactly the same thing for inhalers to move from pressurized meter dose inhalers down to dry powdered inhalers, which both from the anesthetic side and the inhalers, there are things that are up to 20 times less polluting. And we're fully aware of that, and we're just working through the process. That again, that will go through the new governance structure, which will come in place very shortly. So yeah, that brings the presentation and my spiel to an end. And there's, I suppose I'll hand back for any questions.
Thank you. Thanks, Liam. It's good to hear of all the good work you're doing. I have to say, when we asked for this, we didn't realise you had been doing so much good work, so it's great to hear. In terms of the net zero plan, I mean, every local authority up and down the land is drawing up, or some have already done it, their sort of carbon reduction plan. Is this going to be the main document to which you then work towards with your targets to try and do what you can to reach net zero? And can you just tell us a little bit more about the governance structure? What does that look like? Are we going to have a climate board like you have a risk board, sort of meeting monthly with sort of you and other people being held to account, sort of saying, look, what are you doing? How are you doing this? In the same way that the risk board does that in terms of finances and things like that. I mean, how seriously is it being taken at board level?
To start off with, the net zero plan is exactly that. It will set out the short, medium, and long term goals, but also the broad themes which we're trying to meet. But it will also then look at specific tasks. The governance structure will also be exactly that. The proposed structure is that it will be chaired by an executive director. There is a structure in place where it will report twice yearly into the board, but obviously as and when required as well. It's also got potential, as other trusts have done as well, to have a non-exec director on it. But it would also have key stakeholders. I think it's important to know that though that reporting structures there, to have key stakeholders within the clinical and medical teams and the corporate teams, and to have their input, because there are a huge amount of sustainability champions out there. When we started to do our gardening club, overnight we had 75 people say they want to grow vegetables and do gardening for the trust and support with that. So there's a lot of interest out there. The concept of that governance structure is that there will be an action plan associated with it, and the teams will be held accountable, and it will report, as I said, twice yearly up into the board with actions and conclusions from that. So I hope that answers your question.
And just before I open up to members, I mean, obviously we're becoming far more aware of it, and rightly so, as a local authority. I mean, to what extent are we, and I'm also looking at Cllr Kennedy here, thinking about ways, obviously the council, Homerton, the NHS are probably some of the biggest carbon footprints in the borough. To what extent are we working together and sharing ideas? So whatever the Homerton's regular meetings are on it and the councils, is there scope for joint working leads, attending both and learning off each other and working together in a more cohesive way?
So some of those meetings are already taken place. So from a Homerton perspective, we join the NHS one, so NHSE and I. We have local partners through the MPAG groups, as I alluded to, but there's also the ICS works. We're in contact with sustainability leads from the council as well already, and we've committed to joint working across the entire patch. So I hope that answers the question as well.
Councillor Kennedy, from a council side, I mean, what thought have you given to you know, this area, it's obviously not an area other than adult social care where we have sort of direct control, but it's in terms of trying to encourage all our partners. I mean, it sounds like Homerton are doing a very good job, but, you know, benchmarking that with what the council's doing and looking at the council's role, not just say within the council, but as the wider area.
Yeah, I don't think it's so much as benchmarking different organisations against each other as working in tandem. And the conversations I've had with Mete about it has been that there's a lot of partnership working going on, not just with NHS colleagues, but with colleagues across other partner organisations. So actually, I was about to quote HUHFT, but of course HUHFT are another NHS organisation. But yeah, it's not just with the Homerton, and some of the expertise lies and the ability to analyse outputs over the whole piece lies with the council, and of course we're sharing that.
I see Laura, and then I'll open up to members. Laura.
Thank you, Chair. Liam, amazing piece of work. I pay tribute to you and the Homerton for this. It's just really quite remarkable. I was really impressed by your presentation, and it was very clear for a person who doesn't actually understand this very much. It was, you know, it was in good lay clear language, so well done on that as well. I think general practice is nowhere on this. I mean, that's not a criticism. They're tiny, they're pushed, they haven't got the sort of infrastructure and ability and governance to do this, but we've got not just the GPs but the pharmacists, you know, all these little buildings everywhere. I bet there is some learning that we could take from what you've done about, you know, what would be the top 2 things that small bits of NHS could do with not a lot of infrastructure to support them. So I'm wondering whether outside of this we could lock in somehow to just think through what those, you know, if you're, I don't want to put you on the spot, but if your top 2 things for a little tiny surgery that's only got a practice manager, but they wanted to get on board with this in some way, where would they begin? Maybe we could talk outside the meeting, because that's also probably, you know, some learning from you and your expertise in the Homerton that we could build across the City and Hackney system. Yeah, great work, really impressive work.
Happy to connect outside of the meeting, of course.
Councillor Snell.
Hi. Yes, a great bit of work, and you seem to be working off a well-developed national NHS model. It always seems to me it's quite hard work to supervise improved insulation works, but they're such a no-brainer. You know, before you start doing all the trendy stuff and the new heating systems and solar panels and everything else, you don't want buildings that leak heat. So 2 questions on this front. First of all, you talk about the film on the windows referencing solar gain. Well, clearly film on windows doesn't do much to stop you losing heat, but it may well help you on solar gain, which made me realise that you are looking at fully controlled environments. And I just wondered in general whether your total heating load is higher in the winter or the summer. Is it the case that you're using more electricity now to run the air conditioning in the summer than in fact you're using fuel through the winter to heat the place up? Have you got an idea on that? And then subsequently, I was very reassured when you started talking about energy performance certificates. And this builds on what Laura was saying, because of course, every practice should have an energy performance certificate. And what to me would be interesting, if you wanted to work out the first buildings to focus on, it would be those, if the certificates have been done properly, it would be those with the lowest rating on the existing certificates. And I would be interested to know whether Homerton Hospital, does it have a single certificate covering the whole site, or does it have a series of separate ones for different buildings? Because that process of looking at those certificates, working out the areas that are losing heat most, and then taking immediate steps to put them right would be a way both to make the premises far more comfortable, but also would have a massive and permanent impact on the carbon load.
Thank you for that, and I'll try to answer each of those points. So the electricity, we profile all of our utility use, so through electricity, water, gas. So we look at that also. Obviously, that helps us from a budget setting viewpoint, but also from a management of the utility itself and best practice. We haven't seen a full change of electricity. So traditionally, you would see a higher use of electricity in winter because obviously it's dark at 3:30, 4 o'clock, and through other means. So we're still seeing the traditional profile. However, those peaks and troughs are now we are starting to see rolling hills. So we are aware of that. We continue to monitor it, and that's partly why we're looking to move into away from gas and into electricity and other items as well. So I hope that does answer that. We do profile across all of our portfolio where it is possible. And then obviously from an energy performance or display energy certificate piece, so DEX, we refer to it as. So the Homerton has one for its acute site. Where we have directly owned community buildings, we also have one that the Homerton manages. If we lease, it's done through the landlord. And part of our profiling of where work streams need to take place is directly linked to our display energy certificates. And as you can imagine, the quantity of electricity and utilities an acute hospital uses is quite astronomical. So you do have to look at it across peers and also across the complete portfolio of buildings as well, and actually just take incremental steps of improvement. We do have a building that's 30 years old, so technology has changed. Our patient numbers have increased, and the things like the quantity of MRIs and X-ray machines we have on site, which use a lot of energy, is obviously increased with that. It's how we can respond to it and support the trust with that going forward. But we do definitely take a look at all of those. But with regards to how you using DEX or EPCs as a good way of judging where smaller premises or organizations could look at to improve is definitely a good way, good starting point, and it's the way lots of other organizations do it as well.
Sorry, can I just come back on the thing you didn't answer? From what you've told me, I think you're saying you've got one assessment for the whole of the Homerton site, but you don't have an assessment at the moment that lets you identify the areas which are least well insulated. And I wondered if that's something you could look at in future.
Yeah, so we do one for the entire site. So it's almost like an address. It's done one to an address more than anything else. We do look at the heat gain. There's a heat gain surveys and different things to do, but yes, completely noted. And it is part of insulation is definitely part of what we look at as well.
Councillor Adams?
Yes, thank you, Liam, for your presentation. My question stems from transportation for the staff that are working awkward shift, that at the moment they are making use of their cars. Do you have any strategy in dealing with those kind of staff in the future, whereby there will be no need for them to use their cars to come to work?
So obviously with the COVID environment, that's a very contentious and difficult conversation to have. Lots of people are driving, more people are driving to work. The Homerton has approximately, or it's just under 300 parking spaces on site. There are lots of options that we can take as an organisation, which other organisations have done with regards to reducing and looking at alternative parking solutions. Part of why we've engaged Jump is it also has modules around transportation and educating about actually what your individual carbon footprint is by using your own vehicle to go to work versus getting on buses and trains, etc. It's a very difficult one to try and change that culture, and it's something that will have to be a part of the longer term plan as well. We do encourage obviously bike schemes. We have lease schemes as well. So if people do want to purchase bikes and or lease vehicles, we try and push them towards electric lower emission vehicles. But it's again, at this point, it's somewhat of a choice.
Liam, in your presentation, in terms of future plans, you've mentioned a few spend to save areas, such as the 4.1 million bid. I mean, do you presumably you've got a list beyond that of areas of spend to save, or areas that you know that would further reduce the carbon footprint, but it costs a lot of money, retrofitting, insulation, etc. I mean, what's top of your list that you would want to see? Is it greater insulation across the site to stop the heat loss in the main building? I mean, what's the? I mean, I appreciate that's incredibly expensive to retrofit like that. What's top of your list?
So it's not necessarily insulation. It's more about the hard equipment that we have on site. So we're currently in the process of changing our generators. So generators that were original to brand new energy efficient generators across site. Obviously, resilience wise, that's great, but also from an energy usage are amazing. So big tick on that. We would look at chiller replacement and air handling units. A lot of this relates to backlog maintenance, which is not an unusual conversation to have with NHS trusts. Across the NHS, backlog maintenance is well documented to be very high, and the Homerton is not unusual in that. It does have some as well, but it would be hard kit. It would be things like, as I said, air handling units, chillers, a lot more of the hard kit than potentially insulation. But also, I think one of the things that we do need to look at is how we build sustainability into all future projects, and which we are also doing with our capital team to get that as part a very clear agenda item, and ensure that when we are purchasing new bits of maybe medical equipment, or we're building new buildings, it is to the very highest sustainable specification.
And is there, I mean, obviously you discussed a bit, but is the NHS moving in a place where there would be the spend to save funding that you can pull down upon for these areas increasingly? I mean, is that something nationally that's being budgeted for to enable trust to draw down upon?
So the public decarbonisation scheme is actually in its third iteration. So that seems to be something that's going to continually come around every 18 months. It's roughly an 18-month cycle. It's not an 18-month delivery on it, which should be noted as well, which is one of the things that's changed, but it definitely seems to be from NHS England, something that there is going to be future monies available to ensure we nationally meet these targets. But it will be a challenge. It will be a challenge.
I just had a final question for Tracey. Are there any further questions from members looking? I mean, I suppose the final one I had to Tracey really was picking up on Laura's, I suppose, point I hadn't really thought about before. I mean, obviously, we've asked you here about the Homerton, but obviously now in terms of a Hackney and City NHS is actually wider than that in terms about primary care and all those other aspects. To what extent can you take what you've done at the Homerton and that plan, and do we need to manifest that self in a Hackney and City basis, NHS, which is obviously bigger than the Homerton?
Yeah, I mean, just hearing that question from Laura and thinking about what Liam said with regards to our own community sites, there is a synergy there to think about how do we transfer that knowledge and experience and understanding across the wider City and Hackney patch. When we talking about working as a system, that's talking about sharing. It's talking about working together, it's talking about compromise, but it's also talking about sharing and learning from each other. So I absolutely think we should do that, and we need to think about how do we make it real, really, and how do we make it manageable. But I can absolutely agree with the principle of that. It'd be stupid not to. I mean, it's madness not to.
No, sure. I suppose it's just now. I mean, obviously we've asked for this, but I think from our perspective, the debates that we're having in the council in terms of how we hold the council to account more on this and on a regular basis. So I can imagine this is now something on a more regular basis we'll want updating on. And I think, it may well be that the sort of the next time, maybe in a year's time, it may be asking not just about the Homerton, but about the NH, asking you to have what's your carbon plan for the Hackney and City NHS. And so I suppose I'm just sort of laying that there now in terms of, I think, where we'll be going next time we ask for this. So we sort of see an action plan and targets there as well. But thank you. Thank you, everyone. So thank you very much, Liam. Thank you for all your hard work. And thank you very much. And so with that, then I will draw that item to a close and move on to item number 6, which is the update on the Neighbourhoods development programme. We're joined by Nina Griffiths, who's the workstream director for Unplanned Care. Thank you, Nina, for your presentation. Nina, do you want to kick off? Oh, and so sorry, just say everyone from who's been on that's got things to go off to, please feel free to leave. Nina, over to you.
Hi, thanks for having me. Jalith, when he was inviting me to this committee, told me that I hadn't presented here since 2019. So that feels like a really long time ago. So it's probably a good time for me to come back and talk about this programme. Hopefully those of you who were here back in 2019 remember that Neighbourhoods is our model for delivering locally integrated health and care services in City and Hackney. It's our model for thinking about delivering services around populations of 30 to 50,000 people, and using that local, hyper-local population as a structure for engaging with local communities and addressing local health inequalities. So Neighbourhoods is still very much a key strategic deliverable for health and care partners in City and Hackney. Still very, very important to us locally. And also it's still in line with national policy drivers. So even through the forthcoming NHS reforms and legislation changes, neighbourhoods or delivery of local care at a neighbourhood level, looking at populations of 30 to 50,000 people, absolutely continues to appear in all of the national policy guidance. So we're still very much supported and pushing forward in line with the national direction of travel. We've obviously been living through and continue to live with a pandemic, and while that has made us all kind of, it's been a huge upheaval to lots of things across the borough, I think the experience of the pandemic has actually really reinforced that this is such an important programme for us. It's shown into harsh light our existing health inequalities that are really quite entrenched and exist across our borough. It's shown the importance of having strong, resilient community and out of hospital services that work together to keep people well and keep people supported close to home. And it's shown the importance of working with local residents and local communities to really understand what matters to them and think about and address what matters to them. And that's really at the heart of the programme. So whilst a lot of things were swayed and changed in terms of progress and prioritisation during the period of the pandemic, we haven't changed the strategic direction of the programme overall. We're still trying to do the same things that we set out to do when we started this back in 2018. So I'm going to talk a little bit about some of the key achievements that we've seen in the last year or so in the programme. And I think it's been we're at a really exciting point in the programme now, where a lot of the services that we planned to deliver around a neighbourhood footprint are now operating around that neighbourhood footprint. So a lot of our community services and social care services are now working around neighbourhood footprints and really working together to form that core neighbourhood team. And we've also implemented a number of the neighbourhood services. So we have neighbourhood MDMs, multidisciplinary meetings running to support people with really complex social and physical health and mental health care needs. We've also really developed our model of community navigation. So how do we identify what matters to people and really work with people to think about care plans to support what matters to them and link them into and support them into accessing wider services that are not just about health and social care, but those kind of wider community services, and really taking a strength-based and an asset-based approach to that. We've also developed what we call our kind of neighbourhoods partnership model. So that is how we bring together local statutory, community, voluntary sector services with residents on a neighbourhood footprint to think about what matters to local communities and local residents within that neighbourhood, and really start to think about how to problem solve and how to address those needs. So some of you may have been involved in the neighbourhoods conversations that we've been running across each neighbourhood for the past year or so. Some of you may have also been involved in the Wells Street Common partnership. So this is a model that's evolved out of both, that's arisen out of both of those two models, as I said, a structure for bringing together voluntary sector, community, statutory services to really think about what matters at a neighbourhood footprint. You asked specifically about, engaging the full set of stakeholders that need to be part of the neighbourhoods programme. And indeed, we've always had broad ambitions that this is about health and social care services for sure, but it's also about thinking about the wider determinants, and it's about more than just health and social care services. And I think we have shown that. So within the services that we've developed, so within the neighbourhood MDMs and within the community, the model of community navigation, we do involve a broad range of community sector, voluntary sector organisations, as well as the kind of wider services in the local authority that don't sit purely in health and social care. So whether that's housing needs, benefits, welfare advice, and those kind of wider services. So I think there's been great progress in really making sure it's a whole system model that does think more than just about people's pure medical needs. You also asked about how we make, what does this mean for patients? And I've included in my report a number of case studies that I hope demonstrate how the services that we've put in place really think about, really do work with individuals to find out what matters to individuals, and really think broadly and holistically about how to address those individuals' needs and bring together the right partners across the system to really be able to address those individual needs and to deliver real benefits for those individual residents. We are working with Cordis Bright, so they are our evaluation partner. They've undertaken a stocktake review of the programme, and we are now working with them off the back of that to develop an outcomes framework. So we really hope that in the next few months we'll have a clear view of what are those outcomes that we should be seeing at a resident, community, cohort and full population level as a kind of result of impact of the programme. So that's something we will be developing with them over the next few months. We're also, I think, part of the reason we were doing the review with Cordis Bright at this point is we are at a point in the programme where we're starting to think about how do we make this business as usual for City and Hackney? How do we stop this being a programme and make this just the way things are done in City and Hackney? And that's not saying that neighbourhoods will end. We want neighbourhoods to continue, but we want to, as the programme to date has been funded by a chunk of non-recurrent monies that have been committed through the Better Care Fund. It's been fantastic that partners have felt able to commit that money through the Better Care Fund to support the programme. But we know that if that's not sustainable, we need a sustainable funding route, and the kind of move to that sustainable funding route. And that doesn't mean we're going to keep on asking for more money. That means that neighbourhoods should be delivered through core budgets, and that move to scaling back and scaling down the non-recurrent programme funding and expecting neighbourhoods to be delivered through core budgets is really important. It's important that we time it right as well. If we do that too quickly, we won't realise the full benefits from the work that we've done to date, and we won't fully embed the models of care. And we've got more models of care, we're still developing those, there's still more to do. But likewise, if we keep on funding partners to work on neighbourhoods through non-recurrent additional chunks of money, it doesn't allow the model to become mainstream. It risks this being a siloed thing that happens alongside and doesn't make it a core way of working in City and Hackney, which I think is really important. So as part of our review, the work we've done with Cordis Bright, we've done a long look back at the programme since its inception, which I've included a summary of in this pack. We've also done a look forward, and we're looking to move over the next 2 years to what we're calling a sustainability plan for neighbourhoods. So reducing the funding, the non-recurrent funding in the programme incrementally over the next 2 years, and looking forwards after that point for things to be funded through core contracts and through business as usual funding streams. That said, some of the key things that we do want to achieve in these next 2 years, as I mentioned, we're developing the outcomes framework, and we really want to make sure that what we're delivering does deliver on the outcomes that we think the programme should be delivering in. Secondly, one of the other key deliverables for the next year or couple of years is we've done a lot of work with services, reorganising services, developing new models of care. And I think the next big challenge is how do we drive the OD and cultural shifts across all of our workforce to really make this real and really realise the benefits that are needed for neighbourhoods. And that's a piece of work that we literally are just kicking off, working with the workforce enabler in City and Hackney to design a system-wide OD plan that gives staff, drives the kind of cultural shifts needed to make this way of working real, and also train staff and equips our staff to be able to deliver these new models of care and realise the benefits for these new models of care. So in conclusion, a lot has happened. I think there's been a load of progress. We're still very much supported at all levels of the system in terms of the programme, and I think we're really excited about thinking forward over the next few years to really making this programme real, this neighbourhoods real, but really making it into the business as usual, the way that things are done, rather than being delivered through a kind of standalone programme as it currently is.
Thank you, Nina. Can you just explain how does in a core sense, how does neighbourhoods differ from primary care networks in terms of because isn't that what we should be aiming for primary care networks or not? How would you define them as different, or they're not?
Yeah, really good question. And I've included a section at the end of the paper in terms of how the programme relates to primary care networks. So it's fair to say that primary care networks are the groups of GPs being brought together within the neighbourhood, and our PCNs are co-located with our neighbourhoods. And there's a huge amount of overlap in terms of their ambitions and their intentions. Though it is fair to say that within PCNs, there's also an element of PCNs that is just about primary care. So some of the asks on PCNs are about primary care sustainability and delivering some core primary care services like extended access and a few other services that are really just about primary care. So there's a huge overlap, but it's not a complete overlap. We work really closely with the primary care networks within the Neighbourhoods programme to support them and work together to deliver the broader ambitions of the Neighbourhoods programme, which align with the broader ambitions of primary care networks. So if you read the documentation and the kind of policy direction around primary care networks, the ambition is for local community services to be organised around primary care networks and to work hand in hand in an integrated way with primary care networks. And there's also broader ambitions around addressing health inequalities that primary care networks are tasked with delivering. So there's a huge amount of overlap there. And we have agreed with the local primary care networks in City and Hackney that we are working together, we're pulling in the same direction, and indeed we're supporting them to deliver a lot of their kind of service asks through the programme. And we're in a process of bringing together our programmes much, much more closely. So we have one joint post who works across the Central Neighbourhoods programme team and the office and the PCNs. We've merged our key kind of delivery meetings. So we used to have a neighbourhood steering group and a PCN strategic delivery group. We've merged that into one group so that we're all pulling in the same direction. And we're working with them to see how we can further make sure that we really do further bring together what we're trying to do with them. We've got a lot of the levers and a lot of the skills and capacity to deliver what they need us to, what they need to deliver. And they've got the reach into primary care. So who knows, there may be, we may change names, we may change labelling, but there's so much in terms of deliverables, and that's, as I said, we're going through that process of really bringing together the programmes and making sure that we're all using the same levers and making the most benefit from the same journey that we're all on.
Thank you. Members, Councillor Snell?
Hello. Reading this report, I understand we have to put all these procedures and processes in place, but I was struck by the failure to mention the GP Confederation. I always think that's one of the most wonderful organisations we have within the health economy of this part of London. And I would expect the GP Confederation to be setting standards for engagement across GP practices and providing a platform for GPs to say what they think works well and what doesn't work well. So could you perhaps explain to us why they're not mentioned in this report?
That's a really good point, Peter. I think so. Laura and her colleagues at the GP Confederation are absolutely core partners within this, and they've done a lot of doing on a lot of, and are really working really closely with us on a lot of this. So a number of the projects, the community navigation project, they've been, core to developing that model. They've been core to supporting the PCNs to help the PCNs get to the point where they are at right now. They've been core to thinking about models of care and what community services should look like and how community services should interact with primary care. So I think it's purely because I probably tried to put such a strong lens on the PCNs just because there's such an overlap between the PCN agenda and the neighbourhood agenda, which is very important. I think the Confederation are kind of a partner there, both supporting the PCNs and also supporting a lot of the development of a lot of the models of care within here. Laura, I don't know if you want to add anything more to that.
We're in there, don't worry. Yeah, I mean, it's critical work to, this is the way in which we're going to get really real about health inequalities, population health, things that the GP Confed, amongst many others, hold dear. We are absolutely at the table. If we're just not highlighted in this particular report, don't take that to mean we're not fully in the picture.
Thank you. And Nina, you alluded to it at the start. What sort of budget, non-recurrent budget, has been put into neighbourhoods that won't be there in, say, 2 or 3 years' time? What sort of figure are we looking at, or and how many full-time equivalents does that equate to?
I can give you the figure. So over the past, each year for the past, since 2018, it's been 1.14 million. Next year, we're looking to drop that to 738k, and then that will drop again in the following year. Number of whole term equivalents, I'd have to come back to you, Ben. I'll have to quickly start counting that up, but I can let you know.
And sort of what, and just broadly speaking, in terms of the roles, what sort of roles of position has that money been funding? Is it where has it been going?
Yeah, good question. So it has funded a small central team that work to me. So we have a programme lead and a couple of project managers that work as part of a central programme team to provide overall kind of coordination and programme governance to the programme. The rest of the money has gone directly to the provider partners who are involved in the Neighbourhoods programme. So to allow that kind of bottom-up co-development of new services, new models of care. And in most organisations, they have funded a project management type post and a clinical lead type post, or a couple of clinicians to be part of it, so that it's or practitioners to be part of it, so that it's really developed with clinicians, practitioners at the front of developing the model. We've also funded HCVS to support with developing the model for community and voluntary sector engagement, and also Healthwatch to support us with both resident involvement in the actual programme, so Healthwatch facilitate our neighbourhoods resident involvement group, and also to develop the model of resident engagement at a neighbourhood level as a kind of ongoing model going forward.
Thank you. Thanks for that overview. Members, any more member questions before I sort of bring this item to a close? I think, no, I mean, thank you for the update, Nina. I mean, I think then with the tail off in funding, I mean, yes, you've obviously commissioned the piece of work in terms of the outcomes. It would be obviously good to understand what the consequence, or what the likely consequence of the sort of the drop off of funding would be going forward, if it's not embedded or replicated, and what this sort of means to the system. I guess it may be we don't know until it's not there, and then it sort of puts more pressure on the rest of the system, and that's just an added something else. But but it would be good to understand that when you've done that evaluation report, maybe bring that back to us and understand what that's said there and what learnings. I've got Cllr Plouviez who'd like to come in for a final bit before I bring this to a close.
Oh, sorry. Yes, I do have a question. I know that PCNs have had funding for social prescribers, and I just wondered how you do, given that they're a sort of, I suppose perhaps the centre of the NHS's aim at preventive work and sort of bottom up person-centred preventive work. How have they fitted into the current neighbourhood programme?
Yeah, good question. So they're right in the middle of what I call the model of community navigation. So our model of community navigation is thinking about exactly how you do what social prescribers, among other staff, do, which is work with individuals, develop personalised care plans with individuals, understand what matters to individuals, and then support them to access services that will address those needs and meet their plans. So the social prescribers that are funded through the PCN national contract, national monies, are very much part of that model of community navigation. In City and Hackney, we already had social prescribing services delivered by Family Action that were part of that community navigation, broader community navigation model, and the social prescribers that the PCNs have employed are also provided by Family Action. So they're very much they were made as additional resource within an existing service, and they're very much a core part of our overall model of community navigation, and they are the practice-based element of community navigation. So really that element of community navigation that is in the practices, working with GPs and taking referrals directly from GPs.
And just that's Family Action is I presume a local voluntary sector organisation.
Correct.
So if the social prescribers are located in the practices, so are they on a day-to-day basis, how are they managed and supervised?
Yeah, so they follow a kind of so they spend a number of their days across the practices within the PCN, and then a portion of their week within a kind of central team, so they get that kind of overarching professional supervision and support from Family Action. Family Action are a local charity, you're right, and they provide a lot of these kind of models of social prescribing in various different settings. So they've got very specific expertise and a lot of knowledge as well of the local community and local services that are out there. So so for the individual social prescribers, they have local support from within the PCNs and within primary care, but they also get that supervision as well from their kind of professional supervisors within Family Action. And that's the model that a lot of the PCN additional roles have followed. So the team members work most of their days in the practices, but they also get professional supervision from someone of their own profession within the host organisation.
Okay, so and is that a model that will continue to be as part of the neighbourhood's way of working for all staff within that? Is that something that's good?
Yeah, so I think we take the. I think we would think about it on a case-by-case basis. So, for example, another role that was funded through the PCN contract was the first contact physiotherapists. So physiotherapists working in primary care. For those posts, there was no existing physiotherapist resource within primary care. It's not a professional group that primary care generally employ. So it made sense for them to be employed and hosted by the Homerton, receive their professional supervision and support and skills development from the Homerton for 1 day a week, and also develop links with the Homerton community locomotor service, but then spend their kind of practicing days out in the practices. However, another type of staff that PCNs were funded to recruit were pharmacists. Pharmacists are already an existing professional group that work in primary care, already working in primary care. So for the pharmacists, it made sense for those posts to be actually employed much more locally within primary care, and they don't need that kind of central supervision support from an umbrella organisation. So we've been taking it on a case-by-case basis, depending on the professional group.
Okay, I'll accept that. I mean, social prescribers are not actually a professional group, and there isn't a professionally accepted form of supervision, but I'll let it rest there. Thank you.
Ben, I think you're on mute.
You're on mute.
Thank you. Thanks, Nina. I think once that evaluation's been done, maybe that might be another appropriate point to come back and then take learnings from that and take it forward in that way. But thank you, Nina, and thanks for coming. So I'll draw that item to a close. Final item is the COVID update. It's in two parts. We're joined both by Rob Miller, who's our strategic director of customer and workplace. It was head of IT last time. A new title, Rob, and then Chris. Can I take Rob first, I think, and then go to Chris? So we've got two separate papers. Rob, yours is entitled Future Workplace Update. So I think this is COVID, both staff side, what sense we're getting back to normal, but also in the customers, to the extent you can speak of it, the sort of the customer facing aspect as well. I mean, we noticed, I think tonight for the first time, the town hall front doors are actually open, maybe as a slight change. But Rob, over to you.
Thank you very much, Councillor Hayhurst. Yes, we obviously job titles changing, but so my responsibilities now include customer services, which encompasses facilities. So I work really closely with strategic property services, Chris's and Sandra's team in public health, and teams across the council in our arrangements. So just to give you a quick whistle-stop tour through the sort of summary here. So the overall picture we're operating in is with really helpful guidance from the public health teams, making sure that we're clear about the things we need to take into account as we plan our workplace and customer service arrangements. So we're not assuming the pandemic is over. We know there is still a high level of infections in Hackney. We know also we have a high percentage of unvaccinated residents. So we're planning in the context of that. We're trying to make sure that we're moving our services into as normal an operation as possible, noting how much has been achieved, for example, in staff continuing to deliver services while many of them have been working from home. But we are trying to move towards something that's more normal, but do that in a cautious and sensible way that reflects the guidance from the government and the advice of our health and safety and public health teams. When we were looking at this, so we started planning very early on in the spring, when the roadmap out of lockdown was published, and we wanted to set clear priorities because there's a lot of work involved with each of these, and we wanted to make sure that we were clear with all of our staff and the organisation and our customers about where we're paying our attention to first. So before we looked at any office arrangements, the first teams that we've been focusing on are those teams whose work is non-office based, the majority of whom have carried on working in their normal workplaces throughout the entire pandemic. We have, especially because of our insourcing approach, we have hundreds of staff who've been reporting their normal work places of work throughout the whole pandemic. So we made sure that we were reviewing the guidance for their work, helping make sure they had the right advice and the right arrangements in place. Then we looked at our venues and public facing service areas, the areas where the staff share space with the public. So that includes a wide range of different locations, libraries, community halls, our events, as you say, our public service spaces like the Hackney Service Centre. So with all of those, we needed to make sure we were thinking about the welfare of staff and also the welfare of the building users and the customers we're serving. So to give you examples of that, hopefully you'll have seen that community halls are open for bookings. We're taking bookings in our event spaces. Our libraries have removed the need for pre-booked appointments, but all of those have required quite careful assessment. It's not simply been a case of stopping doing things. So we've had to check things like ventilation, have to make sure that we're clear about guidance for example, where staff may still need to take precautions such as wearing face coverings. So again, those areas came first before we started looking at offices. because we had, our teams had worked very effectively at working from home to deliver our services. Then we looked at our offices. The first space we looked at was the education offices on Reading Lane. The reason for that really was linking in with the start of term. In the autumn, we wanted to make sure that we were able to offer more of our normal services for schools and support through that. So we're using 1 metre plus distancing in those spaces. So what that means in practical terms is we can use about half the space we normally use. Some buildings are more tricky. Reading Lane has 2 lifts into the office space and doesn't have other forms of access. So that makes it harder for us to get large numbers of people in and out. And we've now been moving forward with the arrangements also for the service centre and the town hall. Couple of things to highlight. So firstly, what we've said at the moment is those are the only main office buildings that we're planning to open. So as it stands right now, we're occupying about half of the COVID safe space that we've made available in the Hackney Service Centre. We're bringing more staff in, but again, we're doing that in a measured way. Overall, we think we will be able to have much less office space in future than we do have historically. So we're trying to make sure we're sort of thoughtful as we move forward with that. The other thing is last summer, we knew that we needed to do more to support people working from home. So we sent deliveries of equipment such as chairs, computers, screens and the like to about 2,500 staff, mostly within London, but many beyond that as well. And we use equipment that we already had and in our offices. So we've had to buy a smaller amount of equipment so that we can set up the office spaces as we reopen those. Now there's global shortages of supply of computing equipment, so some of that has taken longer than we'd wanted, but we're now moving forward and we're opening up now the final floor of the Hackney Service Centre at the moment. In terms of the office arrangements, so last year we put in arrangements like one-way systems. We've removed those now, but we're trying to be really clear with staff that there are still controls we need people to follow. So we still, as I said, operating on reduced capacities. We're asking staff to wear face coverings where they're moving through spaces we share with the public. And we're still limiting things like capacities in lifts and how many people can sit around a table in our canteen spaces, so that we're not encouraging staff to kind of gather together. And then we're making other arrangements like making sure that our Wi-Fi service is working well. And we're doing some network upgrades to support that. Linked with that, as we move into this hybrid working environment, we're also working on how we support managers with adapting their management and leadership styles. So the organisation development team have run a pilot of leading hybrid teams, which has been rolled out across 66 managers. Some very positive feedback about that. Really interesting to see how much people value just that opportunity to share ideas together and their experiences. There are some more that we want to do, and we're currently, the team are looking how we can scale that up and offer that to more staff. And then we are also looking at other areas where we can sort of really help support that sort of leadership and staff engagement. I think one of the things we're keen to highlight is we have a wide range of different services who work in different ways. So corporate templates of here's how you must work are not the way to go, because the needs of services will vary, but also individual experiences will vary. We know that some staff have caring responsibilities, some staff care for clinically vulnerable residents, some staff themselves are clinically vulnerable, and it's really important that we're taking a personal approach that reflects that. And then the final thing I'll just emphasize is how we are trying to make sure we are doing this by engaging with teams rather than it being done by a panel of experts who tell staff what to do. So we've been running discussion groups with staff from underrepresented groups. We ran some in July, which were really helpful. And we've been doing some more this month. Polly, our Director for Comms and Engagement and Organisational Development, and Stuart, our Head of HR, and I are running monthly sessions with managers, both to share updates to make sure people are all up to date, but also to encourage managers to share their experiences. So, for example, Donna, who led the work recently to bring in more of our children's services staff into the office, briefed at the last month's meeting and really helped other managers understand how thoughtful that work was. It was not simply sending an email to people saying, can you pop in the office now? It was making sure that people have done their induction so they know what to expect. that we've thought about what happens when people come into the office for the first time in 18 months. Simple practicalities like, what do I do to make sure my swipe card is active so I can get in? Where should I find my team? We're also then reporting in regularly to the senior leadership team and our cabinet portfolio leads. So hopefully that's kind of sufficiently broad to kind of show what we're doing across the piece, and really welcome any questions.
Thank you, Rob. I see Councillor Gregory.
Hi, yes, thank you very much, Rob. Oh, I'm echoing. Why is that?
You're not. You're not.
Oh, it was your computer. Yes, I just wanted to ask, is there a kind of short-term plan and a long-term plan for staff to help them kind of plan their lives, really, bearing in mind that there's still a lot of uncertainties about the pandemic? And also, is there a similar plan that we can let residents know about how our services are going to be delivered over the next 6 months, but over the next 2 years, subject to things going a certain way with infection rates, etc. And then my other question, I'm slightly cheating, I'm having two, is that government released some guidance on the 9th of November about venues and events with emphasis on ventilation, etc. So have our plan, should I say, incorporated that new guidance? Thank you.
Thank you, Councillor Gregory. It's very hard to give a kind of a long-term plan over a 6, 12, 24 month type time frame. As we know, the guidance has changed very regularly. We've seen myriad updates to the guidance which covers our workspaces and customer service areas even since July 19th. What we are doing is, I think we've successfully delivered our services throughout the lockdown period. We're working really hard to open as many up to normal as possible. It does touch on your second question, which I think is actually part of the first question. We're making sure that as we reopen spaces, we are carefully considering things like ventilation. So, for example, we've had specialist reports commissioned and provided on the ventilation in the Hackney Town Hall, because while some of the rooms have external facing walls and it's easier to ventilate them, things like the atria and the council chamber don't. So we've made sure that the throughput of those ventilation systems is sufficient to get the right airflow. And we've done things like running the ventilation at full capacity to make sure that the noise it creates doesn't then disturb other areas in the building when it's in use. So as you look at each of these things, there's been a lot of different considerations we need to take into account. In our community halls, part of it is us making sure that we offer guidance on capacities in the space to reflect the ventilation in the different buildings, because they vary quite considerably. It's also important that we're offering the right advice to building users, so that they know the measures they should take. And when we're looking at really important community events, bringing together people, but which may include people who are clinically vulnerable or have a higher likelihood of being vulnerable to COVID-19, it's really important we're offering them advice so that they know what they need to consider and take care of. So, I mean, I have reflected that in a local authority environment, we're incredibly fortunate to have public health within the local authority, because there aren't many employers and businesses who have that level of expertise available at first hand to help think through some of these things.
Thank you, Rob. I see I've got 11 minutes and 10 minutes left now, so can I now at this point just bring Chris in for his part of the report, then I'll throw it open for a final round of questions. So Chris, over to you, please.
So this is my first attempt to do a hybrid meeting, so just bear with me while I try and get the technology to work. I'm Chris Lovett, Deputy Director of Public Health. Sandra sends her apologies. I'm going to try and be as brief as I can, but I'm afraid this is going to be reasonably hard-hitting. If you look at the last 7 days, so prior to the 9th of November, we had 626 cases of COVID confirmed in Hackney. That is a really considerable number of cases. If you compare the period of this period to last year, that's 65% higher when it's expressed as an incident rate compared to this time last year. Whilst we've got slightly lower incident rates than England and London have, generally speaking, been going down slightly, but Hackney has been consistently going up. So we've had a small increase, and our increase has been for the last month. So we have got a very high incidence rate in the 10 to 19-year-olds, and we have been delivering continuing to deliver first and second vaccination doses, and also now the national flu campaign will be delivering at a much greater capacity from this week. There will be some more communication assets that will be used locally to encourage people who are eligible for the flu vaccine, both children and adults, to come forward for the flu vaccine. In terms of boosters, we do know the boosters are being uptaken in Hackney, with about 17,500 residents have had their boosters. It's really important that people who are eligible for their boosters, which now will include over 40s, get their boosters as soon as they're eligible in order to continue to protect them against the harmful effects of COVID. And just in terms of what the impact of the 626 cases in the last 7 days has had, we are continuing to get really high numbers of COVID cases in the Homerton Hospital. We've got some really high occupancy rates, and this is now the highest occupancy rate since the beginning of this third wave of the pandemic. And just if you look at cast your eye across to Europe, where you can see the impact of what are now considered to be fourth and fifth waves of Europe, it's very, very clear that we're by no means out of the danger area at the moment with COVID. So the message really is one that you've probably heard us repeat a number of times. It's really important that people do get their first, second vaccination dose against COVID and also flu as soon as they're eligible for boosters, to get the booster if they're over 40 and over 50 or clinically extremely vulnerable. And also, we are now very much into the cold and flu season. It's really important that people who get often the initial symptom will be cough, is that they actually do go and get a PCR test as soon as they've got any symptoms, which could be COVID, regularly to use the lateral flow testing, mask wearing where they're indoors, and self-isolate if they have got any symptoms. Thank you.
Thanks, Chris. I mean, I see Councillor Gregory's got a hand there. I mean, just in terms of that number of 600 odd in the last week, if I recall correctly, how many of those are 18 and under? Do you know roughly?
If you look at the presentation, there is, oops, trying to get the right one. Just move it forward slightly. So we have then got the breakdown. This is number of cases by age group and week. So the majority of the cases at the moment are in the 10 to 19-year-olds. But what we've also seen, which is particularly worrying in terms of the impact on hospitalizations and potentially deaths as well, is a fairly consistent increase in the over 80s as well. So we have got relatively high vaccination rates in the over 80s, but overall Hackney still does have much lower COVID vaccination rates. So in terms of the first and second vaccination offer, that does continue. It is available at a number of community pharmacies, the local vaccination centres as well. But at the moment, the pandemic is being driven very much in that 10 to 19-year-olds. And then you'll also probably see in the middle of the 40 to 49-year-olds, we're also seeing some increases in case rates as well.
Thank you. Councillor Gregory?
Thank you. I know, Ben, I think I'm getting feedback from your computer or someone else's. Thanks. Yeah, so thank you for that. At the last meeting, I asked about advice given to venues, etc. And there is some general business advice on the council website, but I'm quite concerned that there's high levels of mixing in venues in Hackney. And I wondered what we're doing to be proactive to encourage venues. Are we offering them to help, things like offering them to help look at their ventilation, or asking them to come up with a plan? So I'd like to spot more information, because that's where a lot of people are gathering. And when I was out last week, there was just loads of people everywhere, and it just looks like there's no pandemic in Hackney and in London overall. Actually, people aren't being very cautious. So I just wondered what your view was on that. Even though I know it's not the high risk area, I'm still worried that that's likely to be an infection spreading zone. Thanks.
Thank you. So we have been engaging with businesses, and that's an ongoing engagement process to encourage, as you've said, some of those issues around making sure that lateral flow testing is encouraged before people attend venues, mask wearing where it's possible and practical. Just last, I think it was actually actually this week, actually on Monday, we did do a session which was reasonably well attended around preparing for the party season as well. I think at the moment we are slightly out of step with Europe. The rest of Europe was essentially going into greater restrictions. We no longer have, across the country, higher rates of vaccination than most European countries. They are experiencing really significant pressures now. And I think we have got an indication of what that can look like if you look at the occupation of hospital beds in the Homerton and elsewhere. So at the moment, it is very much about reinforcing that message around we have a safe and effective vaccine. We need that safe and effective vaccine to be administered to people, and we do have 100,000 or so people who really should be looking to come forward and get that first, second, and then when people are eligible, the boosters. And obviously, as we've just talked about as well, the flu, the moment we have a lower uptake of flu vaccines across the country, and that should be addressed in the next few weeks with a very high-profile communications campaign. The flu vaccine is now available in practically every community pharmacy, and lots of people are eligible for the free NHS flu vaccine.
Can I just ask if you've been doing work in the halls of residence? We've got quite a lot of student halls of residence in Hackney.
Yes, so we have been promoting both lateral flow testing when people come back from holidays, vacation holidays for universities, and also vaccinations as well. But again, it is that message that you hear time and time again, and also the importance of testing. People do need to be regularly testing twice a week, and as soon as you've got any symptoms, and often it is quite difficult to distinguish between a cold and a COVID symptom. It's much better to be cautious, stay at home, get a PCR test, than risk coming into work or university lectures when you may have something which you think is a cold, but subsequently could turn out to be COVID.
And Chris, as far as we know, I know Henry Black gave the statistic on a northeast London a month or so ago, but the vast majority of people still in ICU at the Homerton are unvaccinated or only one dose. Is that still being borne out?
I'm not sure if Tracey is still on the call, but certainly the vaccine is working in terms of protecting people from the most serious effects of COVID. As we do get people who are getting towards their 5th and their 6th month since they're boosted, there will be more people who will end up with serious COVID infections, which is why getting that booster is so important. But yes, certainly across the country, the majority of people in ICU are people who have been unvaccinated. I wouldn't be able to give you the exact figure for the Homerton, but I'd be surprised if it wasn't also the case for the Homerton and North East London as well.
And just in terms of the booster, as speaking as someone that was personally quite engaged with what was going on at every twist and turn in this, I've no else, everyone's sort of in a position where they're sort of, COVID sort of become a way of life, as it were, and sort of losing track. Are we really pushing out for when people are eligible for that booster, sending them the text messages, letting them know? How, because people probably just aren't aware as much, and how are we pushing that on a Hackney level?
So the NHS system around text messaging and reminding people and phone calls is now very, very well rehearsed for COVID. So if you have had, your second vaccination is coming up to the 6-month period, I think they're now going to be looking to send out the reminders at 5 months so you can make that appointment. So they are, that process is now very, very well rehearsed. And it's certainly, for my own case, I think I've received about 3 or 4 text messages and 2 phone calls just in the last week as soon as I turned eligible for the booster. So we have had 17,500 residents who've had the booster. There is obviously the fact that it's a rolling cohort, you become eligible, new people become eligible each day. Actually keeping track on that percentage uptake is something that we need probably another couple of weeks to give a sense of certainty as to whether our residents are uptaking the boosters at the same rate as other areas, or whether we may have a little bit more hesitancy. But at the moment, certainly people are being notified that they're eligible and coming forward at a very good rate to get the booster vaccination.
Thank you. Any last round? Councillor Snell, last question.
Well, it's one of my persistent questions, and it's not in this paper, but can someone just give us a quick update? The group that has always concerned me because of low vaccination rates are care workers, independent and family care workers who are not in residential and other formal health systems. This I know is also of concern to the wider Inner North East London Health Scrutiny Commission. The latest we were told was that the reasons they look so bad is it was difficult to collect accurate statistics, which worries me even more. So I just wanted an update on whether we have yet been able to understand what proportion of those people are now vaccinated, whether we do actually have accurate figures for particular second vaccine, and I guess now on booster jabs as well.
So I can see Helen stood on the call, so I'll make some opening remarks and then see whether Helen wants to add. So there has been a really significant amount of work to encourage vaccination uptake for all of the people working in the care sector. And obviously people are aware of now the mandate for older people as well. It is quite difficult to actually get that data very accurate. There has been really significant efforts in Hackney, and they have been very successful to both get a better understanding of vaccination uptake and do a number of engagement sessions, both with individuals and with the care organisations to provide vaccination uptake. I leave Helen to sort of, perhaps she may have some more of the up-to-date information about where the percentages are, but I think in Hackney we have spent a lot of time and a lot of effort in order to encourage people to get vaccinated in all of the care settings.
Helen?
So, Councillor Snell, I'm not quite sure whether you mean unpaid family carers, as in relatives that care for someone that they're related to and live with, or whether you mean care sector workers.
Shall I come back? I'm referring to what was, I think, the original dashboard figures that were coming across, and they were splitting every way under the sun. But there was a clear distinction there between care workers in established settings, like, as I say, residential homes and other formal health settings, and what was called domiciliary care elsewhere, which we were advised at the time included both the people who work for multiple clients and go from door to door, obviously who are at great risk of spreading COVID, and they also, and one of the reasons it was difficult to get accurate figures is that also include family members who might be caring. So that's what we were told at the time, and those were the groups that they said they didn't really know what was happening with them. Okay. So I think they were counted as one complete group in those original figures we were given to Inner North East London.
Right, so the two separate things that you're talking about there, but our domiciliary care, or what we would call home care workers, we absolutely know how many have been vaccinated and have a very clear programme. So we're at about 76.6, well, exactly 76.6% with all of our home care workers. And we have a whole programme of interventions that we are doing with the different providers to keep increasing that number going forward.
Okay, thanks, and go on.
Sorry, I remember being told that one of the problems was often people in that setting were family members, voluntary carers, and I wondered if we are doing the same amount of work to meet, or family members who I guess are getting direct payments from the person they're looking after. Are we making efforts to get out and reach them and just check that they're all getting vaccinated too?
Yeah, so again, these are all slightly different things. I'm more than happy to meet with you and talk you through all of the numbers if that would be helpful. But yes, we are monitoring our direct payments carers as well.
Thank you, Helen. With that, because I think what a way forward might be to possibly have a sort of particular sort of 15 or half an hour chat with Helen on that, Councillor Snell, and then we can sort of maybe drill that a bit more offline just to understand the different categories. With that, because we are slightly over, I'm going to draw the item and the meeting to a close. Can I take the, can I first of all thank Rob and Chris for that item. Thank you both very much indeed. Minutes of the previous meeting, can I take them as read? Yes, thank you. Work programme is at the back of the agenda. I haven't been notified of any other business. With that, I'll shut the meeting. Thank you, everyone.
Good night. Good night.
Thank you. Good night, everyone. Have a nice evening. Well chaired, Ben.